we can figure out who the patient is, but please do keep it confidential. Tonight's session is recorded. Please remain on mute except when speaking. We'd love you to leave your webcams on so we feel more together. If you're able to, you can ask a question by raising a hand or typing it into the chat if you don't feel like speaking out. And at the end of the session, there is an evaluation. Please fill it out so you get your CPD points. A reminder, as always, that our language matters. The words used to talk about diabetes affect the physical and emotional health of people living with diabetes. They also affect how people in society view people living with diabetes. Our words need to show that we care and remove bias and blame. So you might say people with diabetes call themselves diabetic. So why shouldn't I? Well, evidence shows 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes are free to use whatever words they wish. Other people, especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. We'll now pass over to Marcus, who's pharmacist and managing partner and capital chemist with Bathurst, and we've just heard also involved with South Orange Pharmacy. Thanks, Marcus.
Thank you very much, Alex, and thanks everybody for having me on. I have explained to a lot of people here that this will be a strange session from a pharmacist telling dietitians on this talk about nutrition. So please forgive me. I'm not a trained dietitian, but I think what is really exciting is as a pharmacist, people always hear about people being quite focused on their role and the health system not coming together. What I've seen and what we've been able to do in Bathurst is identify that patients can access so much via their home care packages. And one of the most impressive things is food. In pharmacy, we see patients regularly. We obviously know who has terrible COPD or who has chronic pain or who is mentally unwell and can't do some of these things for themselves. We all obviously know that if they don't eat well, that's going to have a huge impact on their health. So what we're doing these days in Bathurst, I look back maybe 1 or 2 years ago and can't believe that we had patients coming in with chronic pain. We would give them a painkiller and say, thanks very much, have a good day, I hope you're okay. The questions are obvious that that person cannot go to the shops on a regular basis, get a healthy meal, come home and cook that for breakfast, lunch and dinner. We know that's not possible. So I think this is a huge opportunity for pharmacies, in my opinion, across Australia to change instead of just providing a medication and health advice, linking them up to other parts of the health system. I can't easily see who else would have the time or the ability to do it. And that's why it's been really exciting for us there. I think this is really obvious, although sorry, that hasn't come through. It's what you eat makes it as dramatic an effect, if not more, in my opinion, than the medicines that pharmacy gives you. It's really huge that we are focusing on what they're eating. There's so many slides on this, and I know that I am a big talker, so I don't want to take too long. But with this, it's just on fibre. I'm going to focus on this slide. On the RACGP website for diabetes, there's a whole thing under the handy section talking about viscous fibre and the benefits it provides for diabetes. But everything else, so for diabetes fibre, it's obviously proven. Colorectal cancer, reduction in stroke, 16 to 24%. AstraZeneca got me to do a talk last year about fibre with COPD progression reduction. It's massive. It was each 10 grams of increased fibre reduced the progression of COPD by, from memory, it was about 30%, but absolutely massive. And these are patients that we know the benefits. I've looked at my own fibre intake and I think I'm pretty healthy, and there's no way I get my 25 to 30 grams a day of fibre. Or previous to this, I didn't. And so I think being conscious of it and knowing the massive benefit that it can provide you is huge. But weight reduction, cancers, diabetes, and more. Protein is the other one we focus on a lot. So I do HMRs, go to patients' houses and go through the medications. And then at one stage, I was with a lady whose mobility was really poor. It's like, so what do you eat? Like, what are you actually doing? It was, cereal for breakfast, toast for lunch, and, a piece of fruit for dinner. And it was like, so that was all she could manage. She couldn't stand at the counter cooking. She had been offered things like Meals on Wheels, but wasn't thrilled with she didn't like the taste, so she declined it. So you look through that, and it's like no matter what a GP does or a pharmacist provides, her health was going to decline. It was 100%. There's nothing, no chance that she wasn't going without the protein. She was going to have sarcopenia progression. Without any fiber, she was obviously getting less healthy. So we give this to patients so they have a rough idea of what amount of fiber they're meant to be getting. Obviously, dietary is best. So if they look at a sheet, which we give a bigger one than this, but for screen's sake, I did a small little slide. If they look at this and say, I would love to have extra chicken a day or whatever they want, that's great. But if not, then we show them what they can look at in terms of improving their protein intake and obviously fiber from the previous slide. So eligibility, it's any patient over 65, or if they're Aboriginal Torres Strait Islander over 50. There's even a caveat if they're potentially homeless for 45. So the majority of our unwell patients are going to fit in this category. And when you look at who's eligible, it's any limitation on their quality of life. So as you guys being diabetes experts, many of them have some limitation to their quality of life. I didn't mention there the purpose, but the whole point of this is to keep them healthy. So this is I've zoomed in on the slide, but when some people talk about home care or aged care, I think there's a huge sense of nervousness from some patients saying, isn't that where they come in and wash you or clean your house? Or, I don't need that. I'm going really well. I'm not about to go into a nursing home, but this is anyone over 65 who would benefit from medical goods and equipment. So that can be knee brace, the falls alarm. It can be communication aids. There's so much that falls under that category. With meals, obviously what we just went through, so many good quality meals, and I won't go into it tonight, but Meals on Wheels is certainly not the only option for patients if that's not what they want. Home modifications. So definitely, if anybody ever said, oh no, I don't want someone to do something for me, I show them this slide and I explain that they are the one in charge of their care. No GP, no pharmacist, no family member can actually control this. We can't call and ask information on their behalf. They're the only ones, unlike everything else in the health system, this is the patients calling every shot. So if they only want to get meals, they can. If they only want to use the medical equipment, they can. They're in charge. So the meals, though, the government makes sure that because of their limitation, they subsidise them. So a $10 meal, look at something in the pictures there. If that costs $10 at a cafe, they'll pay $2 or $3 for it. So there is, in my opinion, no way they can buy or make anything at those quality of meals. They're so healthy. You can buy 1,000 different brands, high fiber options, high protein options. $2 or $3 for a meal to me is just insanely affordable. If I was eligible, I'm sure I'd be looking at it. And choices, you've got Light and Easy. You have 100 other companies. So what we've started doing, we've spoken to dietitians at the hospital for patients with dialysis and looked at what meals would be okay for them. Obviously, sodium and phosphate's part of the issue. I was talking to dietitians and said, for patients with the stroke, what are we offering them? Oh, look, there isn't really an offer, so they have to kind of try and do it at home. There's options for dysphagia where it's pre-packaged, level 3, 4, 5, 6 meals, also subsidised, sent out to them refrigerated with 2-week shelf lives. It really is amazing what is out there for them. It's just connecting them to what they're eligible for. I tried to keep it as short as I could because I have a very big reputation for talking too much. So I thought keep it short. And if any questions, if I've got time, I'm happy to answer anything if that's useful.
Well, the great news is we've got heaps of time for questions. So
awesome. I was very cautious. I'd love to have questions. I think it's more useful.
Look, we've only got a small group tonight, so everyone just jump in when you like. I've got one question, which is when you were talking about the benefits of fiber, was it studied whether that was dietary fiber or supplemental fiber, if you know what I mean?
There is both. So on that, on the handy RACGP website, talks about for each 10 grams of viscous fiber added, and that was not in your diet, that was additional, and went through like Metamucil, all the different brands that are there. And these are the benefits that came out of the diabetes ones. But same for the COPD. It was 10 grams increased fiber benefited COPD by this. the extra 10 grams was this, and the next one was that. And that was the same for the colorectal as well. So they do it by increasing the amount and then what the outcome was. And most of them were additive, not dietary.
Yeah, right. Yeah, it's interesting, COPD. I never would have made that association.
No, that's why I was so surprised by it. And I do know one of the AstraZeneca reps, and I said, "This is amazing." But I can't. Once again, if I had CPD, I would love to know that. And yeah, and the trials are extensive. So once again, happy to send slides because I give these things out a lot because I'm a wannabe dietitian. So yeah.
Yeah.
Marcus, in accessing some of those things that you've mentioned, you can with the My Aged Care packages.
Yeah.
I'm just wondering whether people are told the full scope of what they can get, because my understanding is that they can apply for it themselves.
Yep.
They can ring the number, for instance.
Yeah. In fact, they pretty much have to. So this is the thing. And that's where, and I didn't know either, Marty. Like I had no idea what they could get. So for years, I'd see someone come in with getting things and someone else not. And I didn't understand what was going on. So about 6 or 12 months ago, I was like, this is so frustrating. I have beautiful patients who aren't getting help. And what are they meant to be doing? And that's why I understood. That's why I got so into it now. But I don't know whose job it would be to explain it because you're only going to make a phone call and start inquiring about it when you know it's useful to you. And I honestly think for a GP with a busy practice with patients in there, do you have time to say much more than, oh, My Aged Care could help you? I don't think you really do, or most GPs don't have that time. So practice nurse or social worker, but it's not something that a practice nurse is trained in, or a social worker doesn't see every patient until they need that help. So there is a massive gap of education and how to let the most urgent patients know.
Typically, practice nurses would be discussing that with the patient at the time of doing the My Aged Care referral.
Yes.
But they might not be aware of the breadth of supports available. So that slide's fantastic just to have, like, it's like a menu of different options, really, isn't it? Which of these do you think you might benefit from? Yeah.
Yes. Yeah. And that's the thing. I mean, we have a patient where he was limping in the pharmacy, like really poor mobility. And I was like, look, want to be physio now, but it's like, look, try this knee brace on. Like it is, oh my goodness, this is great. This is amazing. It's free under his package. He's got 20 grand in his package he doesn't use because he doesn't want a lot of help at home. So all this funding's there. But we're giving him painkillers and drugs that are worth so much more, but he didn't know he could get a knee brace. It's just those really silly basic things. The money's there. The government wants him to stay independent. He's already been assessed. But getting that access to it is the clunky part. But yeah, what we've done the last 12 months has been like so rewarding too. I look back at 12 months ago and we had patients who were really struggling. I remember one guy at Hill End who could barely breathe, who was struggling to get his property. We didn't offer him anything. We didn't know it was out there. So we just haven't told these patients what's an option. But now that the home care knows, they'll call us and say, we have a patient, they need this. Can they come and get it right now? Walk in the pharmacy, get it today. That's how far we've got already.
As far as how did you find out about all of this? What was your journey to learning about the supports available?
It was so hard. There's no one government spot to talk to. So there's 3 or 4 different departments. When you call, they talk about their job. I was like, maybe I'll talk to the home care people, and in their defense, like they go in and help people. They don't know the system. They're just doing their role, like we do. We just do our job. And so it was really slow. It was kind of identifying patients, working out how they got what they got, then calling the government saying, why can this person get this and this person not? So heaps of time on the phone. But it has made the whole job more enjoyable. Sorry?
When you say the government, do you mean the My Aged Care line?
You can call them. Yeah, you can call them and get some info. I actually went to, by July next year, this will be gone, but there's CHSP, there's home care packages, and then there's different levels of them. So there was 3 different departments you had to talk to, all providing home care, all with effectively different answers. So yeah, it was really done. That's why I was expressing hope that in July next year, they are streamlining it a bit, which on paper sounds great. The only downside, which I'm noticing for some patients, is they're going to means test things a lot more. And I can just see a scenario where there'll be patients who, there'll be bills of 30, 40 grand a year to access some of the help, which I know a lot of patients might be resistant to. So I'm imagining people who will be resisting care but needing it. But I'm not against the idea of the means test. It's just when you see what patients will do as a result of it will be the worry.
And how did you make it as a business case for your pharmacy to afford spending that time with your
I think it's
patient?
once you understand it though, and we see them so regularly, it's like once you understand it, like everything here, it's like if you can explain it quickly and well and show the benefit to them, patients have to do it. I can't call up on their behalf and do the phone call. I can't ask where it's up to. It's all patient centered. So it's just the quick explanation to them what they can do. Then they come back and might have a question every now and then. But we pharmacists do see them so often anyway. We see them every week or two in the pharmacy, especially the ones who dramatically need this for their chronic condition. So it was a steep learning curve of how to do it all. But now that we all understand it, it's going really well, and it's really enjoyable because they are patients. I mean, Alex and Mark, you'd know this with your patients in your practice. Imagine someone who's really overweight, who is doing the best they can. They've got diabetes. They can't afford any of the other treatment options for weight loss. Being able to help them get access to meals that are going to be very low calorie. They are delicious. Like don't have to believe me. We can get a sample one day that you can all have on the Echo together. But they're genuinely delicious meals that are low calorie and healthy and high protein. You're like far out. They will be on a subsidised Jenny Craig effectively.
Marcus, can I just ask how that just a bit more of the grassroots, I suppose. So you spoke about the gentleman who had a knee brace.
Yes.
So when he comes in, how do you know what they've got on their package? Is the customer actually calling at the time? And then how do you get reimbursed?
Really, really clunky. So really clunky. It's like, and they've got all their rules where they have to have seen a physio or an OT, which is fair enough. I'm not against any of those rules, but it's like, how do you navigate the whole thing? So we've got a physio who does a day in the pharmacy. Like, so they book them. Do they have funding? Yes, they do. Physio can see them, tick on the box. But this is how silly some of it is, that you've got a patient who's got the funding, needs a walker. The care worker wants them to get a walker. They'll need to see an OT to get approval to get a walker, though. Like, that's the kind of stuff you do deal with. So it's very frustrating. But then when you know who they're with, then you can, and because we now know all the providers, patients coming in with their carers, then we can tee them up with the physio. So it is far from perfect, don't get me wrong. And the equipment's probably a bad example because that's the clunkiest part of it. Definitely not good, but the meals is probably the easier part because you can help them access, say, light and easy or something pretty quickly. And patient feedback is great. They're really appreciative.
Alex, Wendy's asked a good question on the chat.
Yeah. So Wendy just wanted to know if there's an easy way to find a list of the meal providers.
Well, technically, I was saying before, so this is where in Sydney, the limit is on our side. So what we've done in the pharmacy now, we've got a big freezer, so patients can access meals from the pharmacy. So we've set it up directly. You've got Light and Easy, you've got Good Meal Co. The problem can be is where they can access them. So if they're not in a town, so obviously Orange is fine. I assume Molong would be fine, Dubbo would be fine, but in small areas, they don't get deliveries. But in Sydney and and Melbourne, there's a functionality where they can use their funding to go to a local cafe. So the option is unlimited. In practicality, that's the hard part. But absolutely, if you went on, the big companies would be Light and Easy, Good Meal Co, and obviously Meals on Wheels. They're the three big ones in regional areas that you wouldn't have much problem accessing, I think.
Right. Well, thanks very much, Marcus. Very enlightening presentation and wonderful to see you cutting a new path through the red tape of government bureaucracy. Well done.
Thank you very much, yeah.
We'll go on now to our case study tonight, which Wendy Arney is going to present. For comments or questions, otherwise we might give ourselves an early mark for the last session of the year. Wendy, did you have any other questions or any concerns that you'd like some help with?
Wendy, what I would like to say to you, and that is that you're doing a fantastic job under extraordinarily difficult circumstances, and it's highly likely that there'll be a poor outcome in this situation, and you will not be the blame of it, bear the blame of it, you know.
Yeah.
Sometimes we're dealing with things that are mortal injuries.
Thank you, Ian. Thank you, everyone. He's a very troubled soul, and at least I know I've tried to do what I can and have some options going forward. And thank you for the suggestions in the chat. If we can get him into our health service, which I hope he'll still be alive by January, we'll get him in to see somebody there. Yeah, unless he goes back to hospital, which is very likely. But I shall be contacting the police again.
Wendy, I think if he does go to hospital, I know you've already done this, but I actually think it's a really good opportunity to pop all your information in writing and send it in. Often I find in hospital, if you can't get the attention of medical staff, actually our social workers in the inpatient space are often really good at recognising when a community situation is untenable and unsafe for a patient, and often really good at advocating. Now, sometimes accessing those people when you're outside the system can be really tricky. But that can be an alternative route, and they're often very willing to take to take the history of, hey, I don't know how to advocate for this person anymore, because they understand that advocacy space. So that's sometimes a way into the MDT in the hospital setting. If you feel that the medical staff are not as receptive as you'd like.
Yeah, thank you.
Well, with that, I might just pass on to Martin for a summary of tonight's echo. Thanks.
Sure. Amanda, can you just say that really briefly again?
Probably
the
not
other way
briefly.
around. Sorry.
Which bit?
Oh, I just slightly distracted. You mentioned MDT another way around.
Yeah, look. Sometimes sometimes it can be really tricky to know where to send your collateral history if you're in the community and you've got a patient in history and you can't get through to the medical officers, or you feel they're actually dismissive. I've often found social workers are a really great person in that space, because they often understand the broader community context, and they understand risk in a different way to some of our other clinicians in the hospital, and they can be a great conduit to the MDT. And bring along that history and raise concerns around discharge disposition, seeing the whole patient picture, making sure that the right history is obtained when a patient's when medical teams are trying to crack the whip and get patients home. They're a really useful conduit that sometimes are a bit more accessible.
When you say MDT, multidisciplinary
multidisciplinary team. Yeah.
What is it? What is that involve? Allied health professionals or doctors as well?
So most units in some form or another, so medical and psychiatric units, will have an opportunity within their setup to have an MDT. Now, that a multidisciplinary team. That would usually entail, it might be a weekly meeting where they sit down and they discuss, say in a acute mental health unit or a longitudinal mental health unit or a medical unit. They'll go through their challenging patients. They might go through every patient on the ward. They might work out, why are they here? What are their barriers? What do we need to plan for? And it generally brings together all of the allied health. So, speechies, OT, physio, social workers, dietitians. I'm going to forget someone. I'm really sorry. It'll bring together nursing, and that should include leadership of the ward nursing, but also it may include other specialised nurses such as discharge planner, ACAT, aged care assessment nurse. If the hospital's got an NDIS coordinator or another sort of disability nurse, or in paediatrics it might be a CNC or a HIF nurse. And it should also bring together the medical team as well. So in a base hospital setup, it would be your registrars and your JMOs, and in your more peripheral hospitals, it might be your GP VMOs.
Thank you.
Pharmacists, that's the other allied health person, pharmacists, of course.
Yeah, thanks very much.
Yep.
Sorry to not have picked it up
No,
better
that's
before.
sorry. It's medicine is a game of TLAs, and it's keep up.
We
I'll just say MDTs happen at all levels of hospitals, so from your district hospital all the way up to your base hospital or tertiary referral hospital.
Yeah, we get reports, say, with somebody with cancer from an MDT.
Yep.
They've talked about it.
So the oncology MDTs are a mainstay of treatment, and they happen everywhere. They're often some of the best organised, not always the best at communicating.
Yeah. Thank you again. So to summarise, thank you very much, Wendy. That was, as other people have said, really challenging story of this man who's 52, an Aboriginal man. This will just not be going through things exhaustively, but with long-term type 2 diabetes, likely schizophrenia, all of the issues in his home that you outlined, suicidal ideas, and I think you said an attempt previously, knives in his home and all of that, the alcohol and ice, severe foot wound, peripheral neuropathy and more. So just to summarise what people have given as advice, you've done a fantastic job. Going into his home, I think, was a huge step, and you obviously really care about him and are advocating for him as best you can. As Ian said, you are doing a fantastic job. It's an extremely difficult situation. There's likely to be not a good outcome, and you won't be to blame. It's a medical and psychiatric emergency, or appears to be. He displays clear psychotic behaviour, as evidenced in his home and in other ways, and he's in danger of dying of his foot wounds, quite apart from other medical problems that he's got. Community mental health teams are usually the best gateway into the hospital system, but he may need a community treatment order and perhaps a guardianship order. Sometimes accessing the mental health system via the police can be effective, and he had been incarcerated previously. There's a concern, as we've said, for his safety, but also the safety of others, including yourself. When you first told us about the knives, I thought, whoa, you're pretty brave to be going in there. Sometimes you need to say it's not safe for me to see this gentleman anymore, and that he's beyond what I've been trained to deal with. So I need to send him back to you, whether it's the community mental health people or others as well. And then what we just went over again with Amanda about social workers may be a way into a multidisciplinary team, and therefore, more attention and care. I'm sure I've left something out, but that's my attempt to summarise things. So thank you again, Wendy. It's pretty hard.
Thanks, Martin. And on the screen's the feedback link, QR code. So that's it for 2024. Thanks everyone for sticking it out to the end. We will come back again next year in 2025, likely looking to get started in February, with dates and topics to be announced. And your continuing support is greatly appreciated. Merry Christmas, everyone.
And to you. Thanks, Alex. And thanks, Ali, for organising
Thanks,
all these
Alex.
things.
Oh, thank you.
Thanks, Ali.
I'm just trying to stop